Hello friends, welcome back to my channel Nurture Nursing. Today I'll discuss regarding the nursing care of patients with COVID-19 part 2. View on the structure of an alveolus. Alveolus refers to a hollow cavity. In Latin, they are responsible for gas exchange. There are two types of cells, type 1 pneumocytes and type 2 pneumocytes. Type 1 pneumocytes are squamous thin-walled cells and which allow rapid gas exchange between air and blood, whereas type 2 cells are cuboidal cells of lesser surface area and they secrete surfactant. They repair alveolar epithelium when the squamous cells are damaged. Surfactant are composed of phospholipids and proteins and prevent alveoli from collapsing. Alveolar macrophages serve as mobile scavengers that engulf foreign particles in the lungs such as dust, bacteria, etc. The angiotensin converting enzyme 2 is expressed in alveolar macrophages. In patients affected by COVID-19, there is a pro-inflammatory response where the immune system is not able to counteract the virus, leading to inflammatory response and production of cytokines, which is called as cytokine storm, by several immune cells including macrophages, dendritic cells, natural killer cells, T and B lymphocytes at the site of infection, thereby leading damage to capillaries and alveoli. This further leads to multi-organ failure. Pathophysiology: binding of virus to ACE2 receptor followed by viral replication. Generally, for patients with good immune system, viral clearance will be at least 80% within 10 to 14 days, whereas for nearly 1/5 of the patients, it migrates to the lower respiratory tract and causes infection of type 2 pneumocytes, which leads to cytokine storm and loss of type 1 and type 2 pneumocytes, thereby leading to ARDS. When coronavirus binds to ACE2 receptor, three things mainly happen. Type 2 pneumocytes are affected, which leads to respiratory failure. The epithelial cells of the blood vessels are affected, which leads to hypercoagulable state, and there is a cytokine storm due to a pro-inflammatory response. There are three stages of COVID-19. First one is early infection stage, pulmonary stage, and hyperinflammatory stage. In the early infection state, the virus multiplies inside the body and is likely to cause mild symptoms. Symptoms of upper respiratory tract dominates. Infection starts when an uninfected person inhales from a pre-symptomatic person. Infectiousness is high on 1 or 2 days prior to the symptom onset. After 7 days, the chance of infection is less. Pulmonary stage, the immune system becomes strongly affected by infection and it leads to problems in breathing and blood clotting. It is divided into stage 2A, pneumonia without hypoxia, and pneumonia with hypoxia. Patients in this phase quickly progress to the hyperinflammatory phase. In the hyperinflammatory phase, a hyperactivated immune system causes injury to heart, kidneys, and other organs. Cytokine storm occurs at this stage where the body attacks its own tissues. Patient deteriorates suddenly, developing ARDS. Nearly half of the patients with ARDS die. Based on the clinical spectrum, they are classified into 5 types. Asymptomatic: here there is no symptoms but swab is positive and normal chest x-ray is seen. Mild illness, where symptoms of URI is seen along with abdominal disturbance. In moderate illness, pneumonia symptoms occurs without hypoxemia and significant lesions are seen on the CT chest. And in severe illness, pneumonia with hypoxemia, where SpO2 is less than 92% is seen. In critical state, ARDS, shock and coagulation defects, encephalopathy, heart failure, acute kidney injury can be seen. This picture depicts that COVID-19 can affect multiple systems like heart, liver, kidney, brain, lungs, pancreas and gastrointestinal system. Effect on the pulmonary system occurs in 2 stages. Early phase, where the viral replication occurs and leads to tissue damage. In the late phase, the infected host cells triggers an immune response and cytokine storm is activated, thereby leading to pulmonary edema. Effect on the extrapulmonary system. It is mainly due to either one or combination of mechanisms such as direct viral toxicity, ischemic injury caused by vasculitis or thrombosis, or RAS dysregulation. In cardiovascular system, the ACE2 receptors that are found in the myocardial cells will have direct cytotoxicity leading to myocarditis. Even the cytokine storm will worsen the coronary artery disease and cardiomyopathy and may be associated with hemodynamic derangement. In hematological system, the ACE2 lymphocyte destruction, which happens due to the direct invasion by the virus, will lead to lymphocyte apoptosis and suppression of platelets and activation of coagulation cascade, thereby leading to thrombocytopenia and neutrophilia. In central nervous system, the virus invades the system via olfactory nerve and the vascular endothelial cells are also infected. This leads to the infection of the brain. In the gastrointestinal system, mainly gut dysbiosis happens, which refers to an imbalance in the gut microbial community, which leads to further development of disorders of gastrointestinal system. The hepatobiliary system, the use of multiple drugs may lead to drug-induced liver injury. In the renal system, there will be an imbalance in RAS and microvascular injury, which leads to kidney injury. In endocrine system, it leads to euglycemic ketosis, which refers to imbalance between insulin and counter-regulatory hormones, which leads to severe dehydration. In skin, pseudochilblains, which refers to COVID dose, are painful swollen bumps that appear on the exposed skin to cold damp weather. And there can be erythematous maculopapular rash, which refers to flat red areas on the skin which are covered with small bumps that are usually not itchy in nature. And there can be vesicular rash and urticarial rash, which are red flat hives which are seen on the skin. These are the references. If you have any doubts, you can comment in the comment box. Please do like, subscribe and share this video.